Mesti Prof. Kita mulai ya Prof. Prof masih mute ya.
Kita mulai deh yuk.
Ya. Okay. We will start. Okay. Assalamualaikum warahmatullahi wabarakatuh.
Assalamualaikum warahmatullahi wabarakatuh.
Good morning, ladies and gentlemen. How are you, everyone? I sincerely hope that each and every one of you is safe and healthy today. I'm very happy that today we can welcome all of you again in a weekend morning for IROS webinar, even though here in Indonesia, things are still very, very bad due to COVID. But I think seeing many of you here joining us give us strength and spirit that we can still move forward and continue doing our best. So welcome again to all friends and colleagues. You are always welcome at our IROS room. And today we have received registration from more than 250 participants from many countries in the region and even beyond. We have had many IROS webinars, more than 30 actually, since the start of the pandemic. We have the keynote series, which is always the popular one. But today we are launching a new series, which is the IROS Cipto Mangunkusumo General Hospital, FKUI, Universitas of Indonesia, and the Ohio State University, the James Comprehensive Cancer Center Education Series. And here we are also planning that our students or residents can engage and participate more actively. So we are very excited today to start this series and looking forward to the next ones. For this first one, we have chosen a very interesting topic. The speech delivered will be titled Single Isocenter Multi-Target Stereotactic Radiosurgery, SRS, for multiple brain metastasis. Our collaborator, Dr. Andrea Arnett, is here. She will be the speaker for today. And she has also the strong team here present, including the chairman of Radiation Oncology Department, Professor Arnab Chakravarti, a very strong figure in the world, is here with us. And also Dr. Joshua Palmer and the panelists, and Dr. Nicole Matkova, the chief resident of radiation oncology from there, is also here. And of course, from our side, we also have the full support from all parties. Of course, full team from IROS, our president, Professor Tati, and then the Dean of Faculty of Medicine, University of Indonesia, our residents, of course, and IRORA is their association. And Dr. Liz Dina will also be here, our President Director of Cipto Mangunkusumo National General Hospital. And we also have very strong panelists from Jakarta, also present here, Dr. Tiara Anindita, our consultant neuro-oncologist from Cipto Mangunkusumo General Hospital, Dr. Setio Widinugroho, our consultant neurosurgeon from our hospital, and also Dr. Abrar, our consultant neurosurgeon from Rumah Sakit PON, Jakarta. So we are very proud to be joined by all of you here today. Now, to welcome all of you officially, I would like to invite Professor Suhartati Gondoweyarjo, Professor Tati, as our president of IROS, to give her welcome greetings. Please, Prof.
Thank you, Mayang. Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen. My fellow colleagues in Indonesia and neighboring countries. We have friends from different countries right now. And good evening to our collaborators from Ohio State University, the James Comprehensive Cancer Center, Professor Arnab Chakravarti, our friends, speaker today, Dr. Andrea Arnett and Dr. Joshua Palmer as the panelists. Welcome also to Professor Ari, our dean. Unfortunately, cannot join us today, but Ibu Liz is still try to connect to this meeting right now. Ibu Liz is our president director of Cipto Mangunkusumo, the National Referral General Hospital, our hospital, as one of the highest and the oldest hospital in our country. To our respected colleagues also present here as the panelists, as it is mentioned already by Dr. Maya, Dr. Setyowidi, consultant neurosurgeon, Dr. Tiara, consultant neuro-oncologist, and also Dr. Abrar, consultant neurosurgeon from the National Brain Center Hospital in our countries. I feel very happy that today we are launching the first collaboration of IROS, our society, with OSU, with this webinar. I remember how kindly Andrea approached me after briefly meeting in Singapore a few years back in the Astro Meet Asia meeting. She really was consistent in building good connections with us and doing good collaboration. She even visited us in person. Thank you very much, Andrea, before the pandemic, of course, and even got the chance to meet our director at that time, Ibu Listina. Andrea shared with us her remarkable academic cancer center with a strong radiation oncology department under the leadership of Professor Chakravarti, a global expert especially for brain tumor. And soon we had so many ideas to work together in radiotherapy practice, research, education, and training, and also in other fields. However, not long after the pandemic is happened, so those ideas on hold. But even during the pandemic, we keep in contact and we agreed that we should start our work with what we can. So we want to start doing this virtually first. As Andrea and we have always thought that education and training should be a big part of our collaboration. So we think that educational webinar series will be great to start with. And we also will have our resident actively engaged to enhance experience and motivate each other. And unfortunately, the Cipto Hospital and University of Indonesia also give us full support on this. So here we are, with our first topic on single isocentral multi-target SRS for multiple brain metastasis. I'm sure all of us cannot wait to hear about it and learn how we can do it in our centers. Andrea, Dr. Joshua Palmer, and of course, Professor Chakravarti himself is here today, and hopefully they can support us toward it soon. We have started also doing the X-Knife in our department since 2008, working together with the neurosurgeons at the time. We use Lexel G-frame and also providing option for stereotactic biopsy and directly contribute with the SRS if the specimen were found malignant. And as we all have noticed in the field of radiation oncology, and technique advance very fast. And so we now have also advanced technique and machine that will be talked more by Dr. Henry Conrad. We'll share our experience later in the session using dynamic MRT or SRS. And we are eager to learn and catch up with the best. We heard from Andrea that they can treat up to 50, even 70 lesions with this IMT technique. Today, we are happy to see many colleagues from neurology and neurosurgeons in the participants. So I'm also looking forward for a great discussion session with our panelists and everyone else too. Thank you very much, everyone. Please enjoy the session. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam. Thank you, Prof. Tati. Now, to continue, I would like to share remarks from our Dean of Faculty of Medicine, Universities of Indonesia, Professor Arif Fahrial Sham. He sends his apologies that he cannot be here live due to a last-minute urgent duty, but that he sends his full support always. So, Dr. Nico, would you kindly put up his screen?
Chakravarti, Chair Radiation Oncology. Good morning. So Professor Suhartati, as the President of Indonesian Radiation Oncology Society, Professor Arnab Chakravarti, Chair Radiation Oncology, and also Dr. Liz Dinaliastuti, the President Director of Cipto Mangunkusumo Hospital, Dr. Andrea Arnett, speaker from Ohio State University Comprehensive Cancer Center, James Cancer Hospital and Solo Research Institute, and also Dr. Joshua Palmer, consultant radiation oncologist from also James, and also Dr. Angela Giselvania, head Department of Radiation Oncology from Cipto Mangunkusumo, the Medicines of Indonesia, all speakers and moderators, and also participants in today's webinar. I, Arif Faryalsam, as a Dean of Faculty of Medicine of Indonesia, would like to extend my warmest welcome to all participants, especially today's guest lecturer, Dr. Andrea Arnett, and also Dr. Joshua Palmer from Ohio State University Comprehensive Center Cancer. And it is such a great pleasure for us to have you present with us virtually this morning. Today's lectures will bring up the topics of brain tumor as a solid collaborations between IRIS Cipto Mangunkusumo Faculty of Medicine and also James. As we know, brain as a sophisticated, elegant, and elaborate maze of tissue and nerve cell that seamlessly control our sense, our personality, and also help regulate vital body functions and control how we move in our surroundings. When abnormal cells grow in the brain to develop a tumor, it can disrupt how we function and will require the right treatment. It needs a multidisciplinary approach. One of its pilot treatment is radiation therapy from Department of Oncology Radiations. We have seen that this treatment is widely accessible. Eager to discuss this issue as a health provider, scholar, and more importantly, as a teacher. I hope that this lecture will enlighten participants and will lead to engaging discussions. Through these lectures, I hope that Faculty of Medicine and also James could extend further collaborations in other fields such as research collaborations or student exchange programs in the futures. Lastly, I would like to give my appreciations to all committee members who have taken part in today's guest lectures. And again, like to deliver my sincerest gratitude to all speakers from abroad that has given his time to share this knowledge with us. Finally, I hope that everyone who gathers here can take benefits from today's discussions. Thank you for your attention.
Okay, thank you very much. And now from the Ohio State University James Comprehensive Cancer Center side, I am very honored and happy that we have Professor Arnab Chakravarty himself here. I actually had the honor of meeting him a few years back. So he was my examiner at my PhD qualifying exam back in Gunma University. So he is a very prominent figure in radiation oncology in the US and globally. He is professor and chair of the Department of Radiation Oncology at the Ohio State University, also the Klotz Chair in Cancer Research, and he also directs the Brain Tumor Program. He was also listed in the Castle Connolly list as America's Top Doctors, and he leads the National Cancer Institute supported radiation therapy and oncology group Brain Tumor and RG Translational Research Subcommittee and Brain Tumor Committee in defining the standard of care for patients with CNS tumors. And of course, he contributed remarkably in science and academics, including published more than 120 articles in top journals, including the NEJM, the Journal of American Medical Association, Cancer Cells, and so many others. So please, Professor Chakravarty, the floor is yours.
Thank you very much, Dr. Mayang and Dr. Suartati. I'm deeply privileged to give a brief introduction to this esteemed group. I'm chair of radiation oncology, as Dr. Bayang had indicated, at the Ohio State University James Cancer Hospital. We wish that we could meet you all in person, but unfortunately, because of COVID, this virtual format will have to suffice. But look forward to brighter days when we can all meet around a common table maybe and get to know each other a lot better as people. So one day that will happen. So just briefly about Ohio State and our program. Ohio State has really rapidly emerged as one of the top radiation oncology programs in the world. Ohio State harbors the very first and only international training center for radiation oncology, thanks to a generous $8 million grant in kind from Varian Medical Systems. We presently have executed over 30 MOUs and MTAs with over, I think, over 30 leading cancer centers around the world, and we're just getting started. We're also launching a destination medicine program for international patients as we launch our Proton Center as well. And all of these formats, we would love to collaborate with Indonesia in terms of research education as well as our clinical mission. Dr. Andrea Arnett serves as our director for global education for the International Training Center, so she can talk to you much more about this important program. As Dr. Bayang had indicated, we have secured over $150 million in federal U.S. grant funding over the past 10 years, ranking us #1 in the U.S. and #1 in the world in terms of grant funding and research. We've launched innovative programs such as our FLASH program, which we were really one of the very first to launch Mobitron Flash. In fact, the first in North America to launch Mobitron Flash with Intraop Medical Systems. We're also the very first to launch Clinac Flash with Varian Medical Systems. And we're also very well poised to launch the very first out-of-the-box Flash Proton Therapy Center in 2023. So all of these components will be integrated within our International Training Center. And I strongly encourage you and your trainees to join us, and we can teach you the latest along those parameters. Also of significance, Ohio State Radiation Oncology has a very active drug development program as far as the development of novel radiation sensitizers and radiation protectors. We have a comprehensive and cutting-edge drug development institute at Ohio State, which has already developed a total of over 300 novel agents so far. And so far, we've developed 30 novel radiation-enhancing drugs in the past 5 years, some of which look highly promising and will likely move on to some form of clinical investigation, either in the veterinary or in the clinical human setting. So really, I think we have very active programs in research, education, and the clinical realm. I'd be incredibly honored, Dr. Bayang, if you and your colleagues visit us at Ohio State once we are safely over COVID, and we can talk a lot more about our latest developments. So thanks from the bottom of my heart for this invitation, and I'm very excited to see the progress of this program tonight. Thank you.
Thank you. Thank you very much, Professor. Yes, I really, really hope that soon the pandemic will be over and that we could visit and meet you all in person and learn much more. And today we are honored to have also the President Director of our center, Cipto Mangunkusumo National General Hospital, with us this morning, Dr. Liz Dina. Thank you, Dr. Liz, for giving your time to us on this Saturday morning, in your very busy days right now, and your support to us always and every time. So may I kindly ask Dr. Liz to greet us all in good spirit and officially open the series. Please, Dr. Liz.
Thank you, Dr. Mayang. Assalamualaikum warahmatullahi wabarakatuh. Good morning, everybody. Good morning, Dean of Faculty of Medicine, Universitas Indonesia, Professor Ari. Good morning, Prof. Suhartati, our distinguished speakers, the committee, and all participants. It's an honor for me to meet you all in this virtual meeting and happy that you are in good health. Ladies and gentlemen, as we all know, cancer is now the second leading cause of death worldwide. And we also know that radiotherapy as one of the main pillars in the treatment of cancer patients. Estimated 40% of cancer patients are cured in radiotherapy alone or in combination with the other treatments respectively. In recent years, the field of oncology has witnessed several technology advances, including more precise radiation therapy and minimally invasive surgical techniques, such as stereotactic radiosurgery, as one of the advanced and modern forms of radiation therapy to fulfill those demands. We, Dr. Cipto Hospital teams, continuously pursue excellent and in situ of state-of-the-art treatment according to global standards and advancement. However, in order to close the gap between the current availability and the demand, the awareness of to expand the access to radiotherapy is required and must take immediate action. 20 programs, one of the attempts in closing the gap, are dynamic and collaborative models of long-term whereby the state-of-the-art center in the HIC established a long-term partnership with an emerging center in a low middle income country, highlighting collaborative training education projects to facilitate accelerated training and the development of specific services and treatment protocols. We are very honored to have Dr. Andrea Arnett, a radiation oncologist at Ohio State University, the James Comprehensive Cancer Center, reach Indonesia through Professor Suhartati Gondowiyarjo, the president of IRAS, and Radiation Oncology, OSUCCC, under the leadership of Professor Chakravarti to build this collaboration. Thank you so much. We hope this engagement could continue for an indefinite period. We believe that approach could lead to many benefits, especially concerning medical education and collaborative engagement. Thank you so much.
Thank you. Thank you very much, Dr. Liz. Now, before I lose anyone in the panel, please, can we take a brief picture in the panel room? So I would like to ask all the panelists to open their videos. Dr. Tiara. So we can take a picture. Okay, Dr. Nico, would you please give the...
Okay, I will take picture. Please hold yourself for 3 seconds. 1, 2, 3. Okay, one more time. Okay, smile. 1, 2, 3. Okay, maybe for the last time. 1,
Oh, okay.
2.
Okay.
Oh, wait, Dr. Abram just joined in again. Okay.
Thank you.
Okay.
Okay, thank you very much. Thank you very much. So now I think we're ready to begin our session. Now I would like to invite our speaker for today, Dr. Andrea Arnett. She is our collaborator in coordinating this collaboration and with these webinars as our first project together. So she's the lead physician for the International Collaborations and Training Center for Radiation Oncology and the Director of Global Physician Education in her department. And she's also the lead radiation oncologist on the Global Health Education Subcommittee, where they are developing university-wide global health curriculum for residents and fellows. So amazing work. So please, Dr. Andrea, I cannot wait to hear your talk. The floor is yours.
Thank you very much. Again, I really appreciate the opportunity to speak and to have this inaugural session. So I'm very excited to be here, and I appreciate everyone's time on both the Friday evening here and an early Saturday morning there. So let me work on sharing my screen here. Okay, can you guys see that accurately? Is that showing the introduction slide?
Yes, perfect.
Excellent. Okay, so today I'm going to be talking a bit about an overview of brain metastases and then spending some time discussing our technique of single isocenter multi-target radiosurgery for multiple brain metastases. Today, basically, we're going to go over an overview of just a brief background on brain metastases, and then spend some time understanding the indications and selection of patients for stereotactic treatment versus whole brain radiation. I'll spend a bit of time reviewing some of the clinical trials and some different perspectives comparing stereotactic treatment to whole brain radiation, and also spend some time discussing the local control rates, side effects, and toxicity associated with CNS radiosurgery. And in particular, we'll review our institutional experience. And then if there's time, we'll also review some case studies just to talk about some of our patients and how well they've done with treatment. So starting with a brief overview. So the central nervous system can contain both can be a source of both secondary and primary brain malignancies. So if you look at this figure on the left, it's kind of a visual representation of the incidence of all of these different types of tumors. And you can see on the left that secondary brain cancers or brain metastases account for a higher number of brain lesions compared to the entirety of primary lesions. So brain metastases are a significant source of morbidity for our patients, and there's something that need to be considered carefully, especially as our patients are having longer overall survival and better response to systemic therapies. This figure here demonstrates the epidemiology of brain metastases. On the left is the primary tumor type, and on the right is the relative prevalence of brain metastases in US populations, at least. And from this figure, you can see that lung cancer metastases are the most common at 48%, and breast is the second most common at 15%. And then we have other carcinomas and adenocarcinomas kind of grouped together in this figure, and melanoma and colon cancers comprise approximately 9% and 5% of tumors, respectively. And this data may be a little out of date because it's a bit of an older figure, but the general trend has remained the same over the past several years. Importantly, more current data than, so importantly, we're finding that as we have developed better systemic treatment options for our patients, we're having improved survival and are having to approach these patients with a different mindset and have a higher consideration for the toxicities and long-term outcomes from our brain treatments. And so this is something that's going to be a common theme that we'll touch upon throughout this talk. So with the advent of these new systemic therapies and new treatment modalities, as well as improved imaging technology, management of brain metastases has become a complex clinical situation. And so the decision of how best to treat a patient is based on the consideration of multiple factors. It requires, and also requires, the cooperation of a multidisciplinary care team. Some of these factors can include include the histology of the lesion, because some histologies either have a much poorer prognosis based on their rapid growth and progression or poor response to systemic therapy, or their resistance to radiation treatment. We also have to keep in mind the overall prognosis of the disease for the patient. Certain cancers just simply, we've not come up with effective treatment strategies. And this is another factor that has to come into play. We also consider whether or not the lesions that we're treating are symptomatic to the patient, and whether we're having seizures, for instance, or mobility issues that could contribute to overall survival issues. Other factors to consider are the availability of appropriate imaging for follow-up so that you can continue to evaluate progression in response to treatment. Systemic therapy, I've mentioned extensively already, and it's going to continue to come up. A key factor is whether or not systemic disease is controlled or uncontrolled, because we may be able to very effectively control disease in the brain, but if disease progresses outside of the brain in other critical organs, then it is less impactful what we do intracranially. The extent of surgical resection can also be considered, as well as the volume and distribution of intracranial disease, and the maximal size of the largest lesion within the brain, which I'll speak to shortly. Ultimately, the goal is to minimize toxicity while maximizing tumor control and quality of life for our patients. This is a complex algorithm that was taken from a relatively recent publication by Dr. Palmer and colleagues, and it demonstrates one example of a decision tree related to some consensus recommendations for management of patients with brain metastases. And I know there's a lot of information on this slide, but I just wanted to include it to demonstrate that there are multiple branches and numerous factors that come into play when deciding how best to direct therapy for patients with brain metastases. And I'll highlight a few of them and some of the studies that reinforce them in the next portions of the talk. I've talked a lot about prognosis. It's a particular importance because when we are deciding how best to choose a treatment modality for a patient, one of the primary concerns is long-term toxicity. If the patient has, if the patient has a poor overall survival of less than 6 months, for example, late effects of treatment are unlikely to be as impactful during that time, and so can be considered less of a concern for that particular patient in a palliative setting. However, if the patient is living for a much longer amount of time, then we need to consider them with more importance. And this figure here demonstrates that there has been a substantial improvement in prognosis for the majority of cancers, at least based on the 5-year survival rate in US populations. And especially if we look at prostate cancer, and I don't think you guys can see my pointer here, but if we look at prostate cancer, there's been a substantial improvement, breast and kidney, as well as the hematologic malignancies. Unfortunately, for some of the other GI cancers, such as pancreas, liver, and esophagus, we've seen less improvement in overall survival, but are hopeful that over the next years, this will continue to improve. Historically, prognosis was estimated based on a landmark recursive partitioning analysis study that polled patients from radiation oncology trials using several prognostic factors, including age, performance status, and whether or not there was a presence of extracranial disease. Over time, it was found that additional factors likely played a role in improving prognostic assessment for patients. And so this was incorporated into the graded prognostic assessment that was derived from these trials. And this disease-specific graded prognostic assessment now includes things such as age, performance status, number of brain lesions, and then molecular markers for specific histologies. And it's been updated to represent the more current overall survival rates. This table in particular focuses in on the GPA, the disease-specific GPA for non-small cell and small cell lung cancer, melanoma, breast cancer, renal cell carcinoma, and GI patients. GI cancers. And this can help inform the clinical decision-making for the treatment of patients with brain metastases from these different primary disease sites. So another question that's been investigated is related to the amount and distribution of intracranial disease. One initial question that was asked is whether the number of lesions was most important versus the volume of disease that was present in the brain. And so, for instance, if we look at this just representative figure where we've drawn the metastases as small circular dots. If you have a patient, for example, on the left with 10 metastases that are 1 centimeter in diameter versus the patient on the right with 2 metastases that are 2 centimeters in diameter, you find, so the first representative image would be a total volume of 5 cc. And the second representative image would be a total volume of 8.4 cc. So one of the questions is which is worse, somebody with a few large lesions versus another patient with several smaller lesions that have a lower volume than the patient on the right, for example. And this is a table looking at some studies that investigated the relationship between tumor volume versus tumor number and overall survival. And what they found was that the volume of disease had a larger impact on overall survival than the number of metastases. And this figure summarizes the findings from several different trials. And this has been consistent from trial to trial. Another important consideration, again, as I've mentioned previously, is toxicity. So whole brain radiation can be a very effective way of treating tumors within the brain, but is it the best treatment for our patients who may have a longer overall survival? No one's arguing necessarily that we should be doing these extensive technologically advanced treatments for patients that may have a 1-month survival or a survival that's measured on the order of weeks. But in thinking about our patients that will have to live with the side effects of this treatment for a long time, we truly have to consider toxicity. Both treatments have some advantages and disadvantages. Whole brain radiation can obviously be delivered in a simple manner, and the plan can be developed quickly with minimal technologic resources. However, the treatment can take between 1 to 2 weeks, depending on the fractionation that's chosen. And there are a number of studies that have clearly demonstrated that whole brain radiation has a negative impact on the cognitive function of patients. In contrast, radiosurgery without whole brain radiation has a decreased chance of negatively impacting cognitive function, but because we're only focusing radiation in very specific areas of the brain, it of course has a higher probability of new brain tumors emerging after the initial treatment, and has the disadvantages that come with the complexity of treatment and cannot be as easily applied at all centers across the globe. This table is a summary that looked at different trials that have compared whole brain radiation plus or minus stereotactic radiation to an arm that did not include whole brain radiation. And as you can see, the cognitive failure rate was lower in each arm where whole brain radiation was omitted. There was a lower cognitive failure rate for these patients. So it's consistently been shown that if we can avoid whole brain radiation, the cognitive function of the patients benefit over time. So I wanted to talk about a few trials. This trial was so it's the NCCTG N0574 trial, which compared SRS versus SRS plus whole brain radiation. It looked at 213 patients, and these patients had from 1 to 3 metastases. Each had to be less than 3 centimeters in diameter. And the endpoint for this trial was cognitive deterioration at 3 months, which was defined as greater than 1 standard deviation in any of the 6 cognitive tests that were administered to the patient. And you can see that at 3 months, cognitive decline was more frequent in the patients that received stereotactic radiation plus whole brain radiation. And this trend continued as they continued to follow the patients for an extended amount of time. N107C was a phase 3 trial of postoperative stereotactic radiosurgery compared with whole brain radiotherapy for resected metastatic disease. In this trial, patients were eligible if they had at least one lesion that was resected, and then between 0 to 3 unresected Mets, and were not permitted to receive chemotherapy during radiation. They were stratified based on their age, whether or not their extracranial disease was controlled, the number of preoperative brain metastases, and then the histology, as well as the resection cavity diameter. And then were randomized to receive either whole brain radiation plus SRS to the unresected Mets, or stereotactic treatment alone to the postoperative cavity plus SRS to the unresected Mets. The primary endpoints here, again, were focused on cognitive deterioration, free survival, and overall survival. And patients were assessed with MRI, but also queried regarding their quality of life and underwent a battery of cognitive tests to thoroughly evaluate their cognitive function on this trial. Here we have the representative data from this trial. On the left, it shows overall survival with the proportion of overall survival percentage on the y-axis and months from treatment on treatment start on the x-axis. And you can see that there was no difference in overall survival between the two different groups. However, if you look on the right at the graph that represents the cognitive performance for these patients. Again, we have cognitive deterioration, free survival on the along the y-axis and months from treatment start along the x-axis. And you can see that there was a significant difference in cognitive function compared to the whole brain radiation group versus the SRS group. And with cognitive function being substantially better in the patients that were able to avoid whole brain radiation. Interestingly, the surgical bed control was similar, but long-term, it was better in the patients that had received whole brain radiation plus SRS. However, with whole brain radiation, it was important that an important finding was that these patients had worse quality of life, more toxicity from their treatment, and had to undergo a longer treatment course, which delayed their systemic therapy, which could be impactful long-term for these patients. So I've mentioned repeatedly thus far in the talk that we have a particular interest in the cognitive impact of stereotactic treatment and whole brain radiation on long-term survivors. And so the two trials that I briefly summarized previously demonstrated, again, that SRS is favored over whole brain radiation for patients with limited brain metastases. And it was felt from these trials that post-op SRS for patients with resected brain metastases should be a standard of care because they have equivalent survival, and it provides better preservation of cognitive function and quality of life and less toxicity than whole brain radiation. And so we investigated the long-term impact of SRS and whole brain radiation on quality of life and cognitive ability in the long-term survivors on both of these two trials, and N107C and N0574 from Alliance. And these figures demonstrate the change in cognitive scores over time based on these different cognitive measures that are detailed on the right. On the left, you can see the estimated mean standardized cognitive score for patients that were treated with stereotactic techniques, and on the right, patients who underwent whole brain radiation therapy. And you can see that overall the trend is towards improved cognitive performance for patients with that were treated stereotactically and avoided whole brain radiation, versus the scores were, the majority of them were reduced for patients who underwent treatment with whole brain radiation. If we dig a little deeper into this data, and I realize this is a bit of a busy slide, but the take home here is these are forest plots, and a leftward shift favors cognitive performance as improved or less impacted in patients that were treated stereotactically versus patients that received whole brain radiation. And you can see that if we group them based on 1 standard deviation versus 2 standard deviations, and even 3 standard deviations, that overall all of the measures favor stereotactic treatment as the least impactful on cognitive performance as measured by the tests that were utilized for these studies. And when we broke it down based on even on individual patient data, this trend continued to be evident. So overall, more patients had a 2 standard deviation decline in greater than 3 cognitive measures at each time point in the whole brain radiation arms compared to the SRS arms in patients that avoided whole brain radiation. And so one question that I do get asked is, so we've seen these differences in cognitive measures. When we really dig into the details, yes, we can measure a difference in performance, but does this really matter to the patient? And I think that's an important question. If it's something that they're not even going to notice the slight difference, is that something that we need to truly be worried about when managing, when making clinical decisions? And as the answer to that, in my opinion, is a resounding yes. In the majority of cases. So these data demonstrated that a 2 standard deviation decline in cognition was estimated to decrease functional well-being and also decrease overall quality of life significantly. And so, yes, these changes are actually meaningful to our patients. They notice them, and it makes a difference for them in their daily lives if we can reduce the impact on cognition as much as possible. So that was data from some of the trials that have already been published and are a good source of knowledge and information regarding cognitive performance. I briefly wanted to mention some trials that are either newer or in progress at the moment that are addressing other aspects of stereotactic treatment of intracranial disease. And I'll just kind of briefly go over these. But there's a phase 3 trial from the Alliance Group A071801, which is comparing post-op fractionated versus unfractionated stereotactic treatment. And this is looking at whether we see a difference in local control based on the size of the cavity or the number of unresected lesions. And so patients are randomized to different fractionation schemes depending on a number of factors. And it will be interesting to see if potentially fractionating in a different manner or not fractionating will result in improvements in local control at the resection bed. We also have a trial looking at, and when I say we, it's the collective we of radiation oncology. Not all of these are OSU specific trials, obviously, but we also have a trial looking at SRS versus whole brain radiation for patients with 4 to 15 brain metastases. Most of the trials that I've been summarizing to you in this lecture are looking at patients that have a much smaller number of lesions, either 3 or less than 4. And so this is a new group that we don't have as much data in. So I'm interested. So we've had some preliminary data from this that's looking promising, but this is an area that needs to be explored further in our patients that have a higher number of brain metastases. And in this particular trial, they are including a relatively thorough battery of neurocognitive functional tests that will hopefully be able to be sensitive enough to pick up the changes that we're interested in quantifying for these groups of patients. And then there's BN009, which is a phase 3 trial looking at intermediate and high brain met velocity patients. So the concept here is that there's preliminary data suggesting that patients with a higher brain met velocity, as in they more quickly develop new metastases over a shorter period of time. And so this may be a marker of poor prognosis or poor performance. And so this trial is trying to dig into the details of that to see if there's a difference in how we manage these patients and what the outcomes would be, whether we're using hippocampal avoidance whole brain radiation with or a stereotactic technique. And then CC009 is specifically looking at small cell lung cancer, which is another area of controversy in terms of how best to manage patients with brain metastases with small cell lung cancer. And it's comparing SRS versus hippocampal avoidance whole brain radiation for patients with less than 10 brain metastases. And it will be interesting to see the findings from this because historically, we have been less inclined to treat patients with small cell lung cancer with stereotactic techniques, but some retrospective studies have suggested that this could be a good option for them, and it will be good to have some prospective data to help direct us. So interim conclusions, just to kind of summarize what we've gathered from this first portion of the talk into comparing radiosurgery versus whole brain radiation. Whole brain radiation has good local tumor control, but this comes at the cost of worsening cognitive function, both acutely and in long-term following radiation. SRS can offer excellent local control for limited brain metastases, and this often is in the setting of less toxicity and improved quality of life compared to whole brain radiation. And early data is now supporting SRS for brain metastases in patients with 4 to 15 brain metastases. And we're going to have stronger phase 3 data to support this as that trial continues to mature. And SRS can also be used for limited brain metastases for small cell lung cancer based off some retrospective, some large retrospective trials. And we await the final results from NRG-CC009 to answer this more definitively. So now I'd like to move into the section of the talk that's digging more into the details of our LINAC-based SRS, or the single isocenter multi-target radiosurgery techniques that we use extensively here at OSU. Now, before I start this, I should say we have an advanced Gamma knife facility. We use that regularly, and we use it for select patients with specific diseases and specific situations. So we have all of that technology at our disposal as well. But over the past several years, and Dr. Palmer can speak to this more when we get to the panel discussion, our LINAC-based SRS practice has grown tremendously. And I think that it's because of the development of these refined techniques and also the pioneering work of people in our department that we've been able to see this expand and really identify some of the benefits of LINAC-based stereotactic treatments for our patients, specifically in this setting. So I'm going to briefly go into a little bit of the details and the methods of how we do this, but of course I'm always available. We're all always available offline to really dig into the nitty-gritty. But basically, it's a technique that uses our LINAC. We use a single isocenter with multiple non-coplanar arcs or conformal dynamic arcs. And the dosimetry for this technique has been validated from multiple institutions. And this is in contrast to an alternative technique, which would be a single isocenter for every lesion, which is more commonly used for CyberKnife, but also can be used with our current LINACs. But in particular, we've found that this single isocenter multi-target technique allows you to still have excellent conformality, good local control, but be able to do these treatments so much faster than if you were having to adjust the isocenter for each individual target. And so this allows us to deliver very highly accurate treatment for 5 or more, even much higher numbers of brain metastases. And when this slide was written, we'd probably treated over 300 patients. I bet that's an even higher number now because I treat multiple cases per week easily. And then I'm only one of multiple CNS faculty. And if you would like to read about this in greater detail, we've published our institutional experience in advances in radiation oncology with Dr. Palmer as the primary author on that manuscript. So our methods, all patients are treated in, if it's a stereotactic technique, all patients are treated in 1 to 5 fractions. And for this particular study that was published in MRI was obtained for treatment, we have treated based off of CT scans, but that's more challenging. We prefer to treat off of MRI, and if we can, we get thin slice or 1.25 millimeter slice thicknesses on the MRI. We do our CT simulation with a Q-Fix Encompass thermoplastic mask. So on the left, I have a quick picture of our Varian TrueBeam Linac, and on the right is the Encompass stereotactic mask that we use for these patients. Of note, you can see that the eyes have been cut out, or at least the mask is designed so that the patient feels less claustrophobic with the face exposed, and also helps us with intra-treatment, or it helps us image the patient and monitor movement of the patient more effectively during the treatment process by having that mask, that area of the face exposed. So the way that we go about preparing and contouring this is that we'll contour each of our GTVs, or in the case of a resection cavity, we'll contour the resection cavity as our CTV. And then for our PTVs, we do an expansion of 2 to 3 millimeters. And this varies by institution. I'm telling you specifically what we do for OSU, but you may find different PTV expansions depending on which institution you speak to. The doses that we typically use are between 18 to 24 gray for a single fraction, 27 gray for 3 fractions, and 25 to 30 gray for 5 fractions. For our treatment planning, we use a Varian Eclipse treatment planning system. And for normalization, we normalize to 95% of the PTV receiving 100% of the prescribed dose. And we will try to escalate the GTV higher than the prescription dose, so we can somewhat mimic the dosimetry of Gamma Knife-based treatments. But the bare minimum normalization parameters are as I've listed here. For the actual treatment, for design of the plan, we use 3, at least for the study that was published, we use 3 to 5 coplanar arcs using 6 MV beams with or without the flattening filter. The flattening filter does allow us to make our treatments faster for our patients the vast majority of the time. Removing the flattening filter. So the vast majority of the time we treat flattening filter free. A standard 5-arc technique for this particular treatment approach would be composed of 2 full coplanar 360-degree arcs and 3 half vertex arcs equidistant every 45 degrees using couch kicks. And then the plans are generated using RapidArc software from Varian. And we treat all of our patients on a robotic couch with 6 degrees of freedom to allow us to get a higher immobilization accuracy. And then we do a daily cone beam CD for positioning and use optical surface monitoring to monitor the movement of the patient. And that's where I talked about how that Encompass mask, having that portion removed, it allows us to more effectively monitor movement from the patient, and it serves as a confirmation that the patient is indeed holding still while we're running through the treatment plan. This is a summary of some of the data from our SIMT experience. And on the left, you can see, sorry, I don't have a pointer here, but overall survival is in the upper left for all of our patients. And intracranial control is indicated with the letter B for all of our treatments. And freedom from salvage whole brain radiation therapy is in the bottom left at C, and D is local control for all lesions. And we found that our 1-year actuarial local control was around 99%. So very excellent local control for these patients at 1 year. The smaller graphs up on the upper right, A and B, focus in on toxicity for these patients, in particular grade 2 or more radionecrosis on the left, and then grade 3 or more radionecrosis for all treatments on the right. And so the rate for grade 2 or more was 1.4%, and grade 3 or more was 0.9%. So excellent, excellent local control, and in what I feel is a very reasonable rate of radionecrosis for these lesions. Speaking of radionecrosis, we actually did look at our cohort of LINAC-based, patients that received LINAC-based treatment compared to propensity-matched population of patients treated with Gamma knife techniques. And we found in this particular and we published our findings in this particular manuscript, we found that there was a higher rate of radionecrosis associated with Gamma knife treatment than our LINAC-based treatments. And again, these are retrospective analyses, so it's hypothesis generating, but it would be an excellent thing to validate in additional studies in an independent cohort or possibly in a prospective fashion. So the take home from that is that we can achieve excellent control in very reasonable amounts of radionecrosis and may possibly be able to achieve a lower rate of radionecrosis with our LINAC-based treatments than our Gamma knife treatments, at least in in patients where we're treating brain metastases in particular. So I wanted to move into, I think we're doing okay on time, but I'll try to do this rather swiftly. I wanted to talk at least about 2 cases just as an example, so you can kind of follow the process with our patients. So this first case is a 59-year-old woman who was diagnosed with triple positive breast cancer in 2012, and she developed metastatic disease, unfortunately, in 2016. She received palliative radiations to bony sites in 2016 and then was treated with chemotherapy, then Herceptin and Perjeta, and then adotrastuzumab. She unfortunately progressed in October 2017 with 18 new brain metastases. And then she switched to Herceptin and Xeloda, as well as a HER2 selective TKI. And when she came to us, her performance status was excellent, a KPS of 90. She had excellent cognition, high level of functioning memory, and limited extracranial disease progression. She'd only had 1 new bone lesion show up. Her total tumor volume, despite being 18 separate lesions, was only 4.47 cc. So these are some representative images of the plan that was developed for her. These are, of course, hard to capture in just a single screenshot. It's much easier if you can scroll through the entirety of the skull, but you can see all of the separate lesions and the dose is indicated in color wash here where we're targeting the lesions. This is a DVH from her plan. So her prescription was to 24 gray to 95% of the PTV total, which is delivered in 3 fractions. The V100 of the brain was 100 centigrade. The V50% was 490 centigrade. The V19 gray was 3% or 40 cc of total brain volume, and V24 was 23 cc. Again, I mentioned briefly previously that we do try to escalate the GTV dose somewhat. So the GT minimum that we aimed for was between 27 to 30 gray. Conformality index for this particular treatment was 1.03, and we were able to meet constraints for the optic nerves and the chiasm, and we had a brainstem max of 22 and an optic nerve chiasm max of 4 gray. Here is just a representative image of one of the fields that was used for her treatment. Again, this is it's harder not to have a video or to be able to scroll through this, but it's a good visual representation of what we're working with here. Okay, so that patient did well. I'll kind of give you a summary when we get to the end, but I then also wanted to, before we do that, I wanted to present a second case. This is a 41-year-old patient who developed lung cancer in 2015, ALK positive. He had 4 brain lesions at presentation and was treated with CyberKnife in July of 2016 and placed on crizotinib. His systemic disease actually responded well, and he had no systemic progression, but he presented to OSU on crizotinib with numerous new and progressive brain lesions, unfortunately. So the plan was to switch to a different agent. When we saw him, his performance status was 100. He was in excellent condition. He had a high level of, he was excellent physical performance level, exercising daily, and also had a very high level of functioning, of cognitive function and memory. And so we had 23 lesions that needed to be treated for this particular case. And we designed a SIMT for these 23 lesions. The GTV total, despite it being 23 lesions, was still only 3.5 cc. And remember, our other patient previously was in the was in more mid fours for her total volume. So again, we treated with 24 gray and 3 fractions, and we used 5 arcs. And this is again some representative images from that plan with the color wash indicating the area of the dose, and then the DVH looking at all of the different tissue constraints and the different optimization structures that we use for generating this plan. And ultimately, both of these patients did very well. The first patient did develop 4 new lesions, but only after 24 months. That was a two full years without new lesions developing, and continued to work full time and had no issues with radionecrosis. The second case that I mentioned at the time of last assessment was 36 months out from treatment. Only 4 lesions remained on MRI, and he continues to wake up at 5 a.m. and run with his dog each day and has no new lesions and no radionecrosis. And this is 3 years out. So both of these patients did quite well with a relatively high number of brain metastases. So, and keep in mind, this is something I didn't spend a lot of time talking about, but I'm treating, let's say, and this is an example of 5 lesions. One of the key things that we're able to get for patients when we're treating them with the Linac rather than the Gamma Knife is make their treatment time so much shorter, which is both convenient for the patient and convenient for the physicians, at least with the regulations the way they are in the United States. So for this particular example, if we're looking at treating 5 lesions using a SIMT approach on a Linac, we could treat that in 15 minutes versus on the Gamma Knife with the multiple isocenters that are required, and depending on the age of your source, you could be looking at around 1 hour and 15 minutes or even longer for having to treat that number of lesions. And that's not counting the differences in the planning time as well, because some of the planning software can be a little less user-friendly depending on your experience with it. So there's a great savings in time, at least, and especially when you get upwards into the number of 15, 20, 30 lesions, it's just not practical to do that number of lesions with the Gamma Knife. And so Linac-based stereotactic treatments open up a whole new population of patients to potentially being able to benefit from these treatment techniques. So in conclusion, whole brain radiation has good local tumor control, but again, worse cognitive function. SRS can do an excellent job with local control for both limited and numerous brain metastases. Early data, again, is supporting stereotactic treatment for brain metastases in patients with larger number of METs, between 4 to 15, and hopefully we'll have data for even larger numbers of metastasis in the next couple of years. SRS can be used for limited brain metastasis, even in small cell lung cancer, and can be very appropriate for many of these patients. SRS with the Linac, specifically using the SIMT technique, offers a number of patient-oriented benefits, such as faster treatment times, not having to use a head frame for patients, all of which are very convenient and can make treatment more accessible and realistic for more centers throughout the country if your machine is appropriately equipped to be able to do this. And we may be approaching a point where there's no real limit to the number of lesions that we can treat, obviously with some caveats attached to that. So that is the end of my talk. I want to say thank you very much, and I'd like to open the floor to questions and to our panelists, and I'm looking forward to a wonderful discussion.
Thank you. Thank you very much, Dr. Andrea, for your very interesting talk. I would also like first to welcome with us today Professor Satya Negara, one of the most senior respected professor of neurosurgery in Indonesia, joining us. Hello, thank you, Prof. And also Professor Jakaria, our pride and beloved senior professor of radiation oncology in Indonesia, is also here. Thank you. And of course, you are welcome to join us in the panel anytime, please. And for all participants, if you have any questions or comments, you can type it in the Q&A box at any time, or you could raise your hand to ask directly to the floor. Now, before we take any question, I would like to first invite the panelists from our Department of Radiation Oncology, Dr. Henry Kodrat, to briefly share our situation and experience to the floor and kindly comment on this topic.
Thank you.
Please, Dr. Henry.
Thank you, Dr. Mayang, for the introductions. Can I share screen, Dr. Mayang?
Yes, please.
Okay. Okay. Good morning to all participants in Indonesia and in Southeast regions. I'm also want to say good evening to our colleague in the United States. So first of all, I would like to thank you for the invitation from the committee so I can become the panelist for this morning. So I will give a brief introduction about the current status of brain metastasis management in our department at Cipto Mangunkusumo Hospital. So this is overview our facility, our SRS program, and brain metastasis management. So for our facility, actually we have 6 bunkers for multi-energy Linacs, 6 and 10 MV, and we also have 2 cobalt bunker. For multi-energy Linac bunker, actually we have 3 multi-energy Linacs. Both of them are from Elekta, Elekta Synergy, Elekta Versa, and Elekta platform. And one of the bunker is installed with the single energy Linac variant unique. And for the bunker cobalt, we have installed with the variant Halcyon and tomotherapy high art. So we have 2 bunkers for CT simulator, one for 4D CT and one for the 3D CT simulator. The 3D CT simulator is the modification from diagnostic CT simulator, from diagnostic CT. So we have one brachytherapy unit with microselectron and one fluoroscopy for 2D simulator. This is the picture of our machine. We have 6 machines. The above is the CT simulator Siemens with the Anjay belt for the movement tracking, and we have 3 multi-energy Linacs and 3 single energy Linacs. And all of our Linacs is equipped with the verifications. All of them have EPIT, extrude tomotherapy. 2 of them have the KV Conbeam CT for the Elekta Versa and Elekta Synergy. 2 of them have MV Conbeam CT from the variant Halcyon and tomotherapy. 3 of our Linacs have triple F. All of them can deliver MRT. 3 of them can deliver VMAT. We have 2 systems for respiratory gating, 2 systems from ABC from Elekta, and 2 systems for Anjay belt. And also for immobilization, we have custom immobilization and abdominal compression. We have Lexel G-frame for SRS. And for treatment planning system, we have several TPS system, Pinnacle, Eclipse, Monaco, and Tomoplan. This is a tomotherapy machine. It has been installed in 2016 with tomotherapy high art, and right now we try to replace with the latest versions of the tomotherapy, the Radixact. Hopefully in 2022 we can install this machine. For the tomotherapy machine, we mainly use for the head and neck malignancy and also for the CNS tumor for craniospinal irradiations. And then 3D brachytherapy, we have HDR, microselectron, and also we have applicator that capable to do 3D brachytherapy. For human resource, right now we have 13 radiation oncology attending. We have 53 residents. For medical physicists, we have 8, And for the medical physicist resident, we have 5. We have 26 RTT and 25 nurse in our facility. For educational program, we have a residency program for radiation oncology. This is the first and the only one radiation oncology residency program in Indonesia. It's also applied for radiation oncology in medical physicist residency program. And we also has been appointed by IAEA for medical physicist fellowship program. We have received 3 fellow from Syria, the country in the Middle East, for the fellow in medical physicists in 2019. Also, our center have the agreement with the RTT training program for the clinical rotation. And then this picture is our comprehensive cancer service. This is one of the excellent service at our hospital. And in 2021, this comprehensive center has been listed in medical tourism program by the Ministry of Tourism. This is the international research collaboration that we do until this moment, and we have done. We have a collaboration with Rijnmond University of Nijmegen in Netherlands. We also have the many collaboration with IAEA, with the Forum for Nuclear Cooperation in Asia. We also have a collaboration with National Cancer Center Singapore and Gunma University Japan. And we also have collaboration with the pharmaceutical company, for example, like Inogen. This is some collaboration that we have done until right now. I just highlight some important collaboration with the IAEA, FNCA. So the next is our SRS program. This picture is our SRS program in 2008, in the late 2008 and the beginning of 2009. At that moment, we use Lexel G-frame for the immobilizations. And for the CT simulator, we use the Foresight CT. And then the treatment planning, we use Precise Plan, and we use for the treatment delivery, we use Elekta Synergy, which equipped with the Condim CT scan. So we have started since this program since 2008. Until now, we have treated more than 100 patients, 134 patients actually. So the most common case that we have treated is slow growing tumor, for example, like hypophysis adenoma, meningioma, or vestibular schwannoma, followed by the brain metastasis, primary brain tumor, and the list is the AVM. So from 2009 up to 2014, for the immobilization, we use Lexel G-frame. Since 2015, we replaced with the frameless method with the double mask. One of the issue in developing country for SRS program is this program is not covered well by the government insurance. So practically, the patient who can receive this treatment is from private sector. If from the public patient, the patient need to receive some funding from the social program. This is the picture of our SRS. So in 2008, we used the Elekta Synergy, and right now we replace with the Elekta Versa HD for the frameless stereotactic radiosurgery. And for the SBRT program, it's also started in 2008. We have treated many cases for the SBRT for HCC. For the lung cancer, only a few cases, and spinal metastasis. Right now, we try to start to treat the patient. So this is the milestone of our SRS program. So as our SRS program is start in 2008, In 2008 up to 2013, we use for SRS only or whole brain radiotherapy followed by SRS boost. And that moment we use SRS using step and shoot IMRT with Elekta Synergy. In 2016 up to 2020, we use the SRS using the step and shoot IMRT and also with tomotherapy. And 2021, we deliver SRS using the VMAT with the Elekta Versa HD. From the 2016 up to now, we have started our program for the hippocampal avoidance whole brain radiotherapy using tomotherapy machine and also sliding window MRT. And also the milestone with the new machine, we can deliver the dose, the peripheral dose in 50% isodose line. In the 2008, when we start the SRS program, the peripheral dose we use is at 70% isodose line. This is the picture of hippocampal sparing or hippocampal avoidance whole brain radiotherapy. We use the sliding window MRT technique in our center. And then for the SRS brain, we use a single isocenter technique. We use with the 4-arc. We deliver at 20 gray in peripheral dose. And the next topic is brain metastasis management. So Dr. Andrea Arnett has given an excellent lecture. I just want to re-emphasize about that brain metastasis not only in quality of life and tumor control, but also in neurocognitive. In the past, the important thing is the tumor control and quality of life. There is several factors that there are several factors that will influence about the treatment decisions, such as prognostic factor, number of lesions, age, performance, and extracranial activity and primary tumor type. And right now, the neurocognitive issue become important, especially how to spare the hippocampus. This is the table for the brain metastasis paradigm. We have several modality and we have several aspects that we have to aware of. For example, the quality of life, neurocognitive, overall survival, local control, distant metastasis. We can look here for SRS, the neurocognitive is better than whole brain radiotherapy. But for the local control, SRS is better than whole brain radiotherapy. And one of the issue in SRS is the distant brain metastasis, which can be suppressed with the whole brain radiotherapy. So for the survival, I think it's depend on many factors such as chemotherapy or other prognostic factor like the volume tumor or the number of lesions. So I think for the brain metastasis paradigm for the treatment, I think we have to consider this factor. For resection, biological agent and steroid, I think it will be answered from the other panelists. And then for stereotactic radiosurgery, for the beam delivery paradigm, we have four paradigm. Fix the patient, fix the beam with proton machine, shift the patient, fix the beam with the gamma knife, fix the patient and shift the beam with CyberKnife or LINAC, and shift the patient and shift the beam with tomotherapy machine. And for the LINAC, there is a different approach. Right now, I think the best is with VMAT, with the multiple arc. In the past, for the LINAC, we use the circular arc or conformal or dynamic conformal arc. But right now, Arnett has been explained to us that they use the VMAT with a single isocenter for brain metastasis management. So how many arcs do we need, or how many isocenter do we need? I think it's depend on what is the target of the treatment. is this peripheral tools or conformity index or heterogeneity index or gradient index or DPH or treatment time? I think it depends on this factor, which one will we choose for the patients. I think for the take-home message, development of stereotactic radiosurgery program needs time, and SRR skill will develop such learning curve. And treatment decision should be based on the patient condition, not based on the treatment planning parameters. I think this is my last slide. I thank you so much for your kind attention.
Thank you, Dr. Henry. And now to continue from the radiation oncology side from Ohio State University, we have Dr. Joshua Palmer as our panelist. He's an associate professor in the Department of Radiation Oncology and Central System Pediatric Tumor, very active with the leading or coordinating position in many top clinical trials in US around CNS, brain metastasis, and SRS. So thank you for being here, Dr. Palmer. Is there anything that you would like to add, share, or comment on this topic?
Thank you very much for having me. I guess I can try to address some of the questions that have been posted, because they sort of bring up some important points. Talking about repeat whole brain and the use of whole brain radiation therapy. For many years, we still gave whole brain radiation therapy as a salvage treatment, even after giving whole brain radiation therapy or prophylactic cranial treatment. That's not as common, at least in the United States anymore, but you can do that. We typically dose reduce it to 20 to 25 gray in 10 fractions. And so after a year, you could do it again. Typically, following whole brain radiation therapy, we would typically try to radiosurgery any progressive lesions. So any lesions that were not there previously, we would typically boost or salvage those lesions. So we don't typically plan to do it, but if there is a progression sometime later, especially a year later, that would be a good utilization of radiosurgery. But you can give another course of whole brain radiation therapy, typically at a dose reduction for toxicity purposes. For the brainstem lesions, typically, there's sort of a variety of answers to that. You can do a single fraction of gamma knife radiosurgery. Some would do about 12 to 15 gray based on size. We typically will do 18 gray to a PTV margin in 3 fractions and try to deliver something as close to 20 to 21 gray to the GTV in 3 fractions, respecting the normal tissue constraints of the brainstem minus the GTV. And so if that's reachable, typically we'll go after that. Cystic components, I think that's a good question. We typically worry mostly about swelling in that situation. There are some institutions that will offer surgery planned after radiosurgery for cystic or hemorrhagic lesions for that reason, because they can potentially be at higher risk of radiation injury or causing swelling from treatment. But we don't really modify our dose or volume, but we do respect that that's a potential lesion that could lead to long-term sort of kind of difficult management if it does swell or become radionecrotic. And so we know that those are potentially at risk for not having worse control. There are lots of reports that the local control for a hemorrhagic lesion is worse. Local control for cystic lesions is not as good as well, but not as bad as hemorrhagic lesions. But dose and volume, we typically keep the same.
Okay.
I think that whole brain radiation therapy, I probably wouldn't choose it based on age, honestly. I think any patient, regardless of age, should be given radiosurgery, at least an option for good performance status. So typically, I think, even an elderly patient, it does benefit, I think would benefit potentially more from not using whole brain radiation therapy. Like in the studies that we had published from the Alliance, the more advanced their age, the more that the whole brain radiation therapy affected those individuals. They typically have a poor functional and cognitive capacity at the baseline, and that's usually a predictor for worse cognitive outcome after. So I think those elderly patients, I think in particular, benefit from a whole brain sparing approach if possible. I think that, so I wouldn't necessarily look at age, but look at sort of volume and cognitive capacity for those patients, and survival is usually the thing that we use.
Yes, thank you, Dr. Palmer. I think we should also give an opportunity for, we'll take questions from the raised hand participant first, I think. I'll take one from, still keeping in the radiation oncology topic first. Dr. Handoko, would you like to ask? Dr. Handoko is also a radiation oncologist from department in Cipto. Please, Dr. Handoko, you can speak. Hello.
Thank you, Dr. Mayang. Can you hear me? Hello. Hello, can you hear me?
Hello. I can hear you.
Yes,
Yeah, I can hear you.
I hear you very clear.
Yeah, thank you. So I have a few questions. The first one, yeah, we know that whole brain is associated with lower cognitive function, but addition of whole brain after SRS or before SRS is associated with better local control. So if we only give SRS, the chance for retreatment is higher compared if we do SRS plus whole brain. And in a country like us where such treatment is not readily available and it is considered expensive treatment, I don't know. We think addition of whole brain, yeah, though it decreased the cognitive function, but it decrease the chance for retreatment. Is that going to be beneficial? And if we want to obtain the benefit of whole brain, better local control, but not decreasing the cognitive function, can we add memantine or maybe do hippocampal sparing? I mean, we give SRS and then we also give whole brain, but we modify both whole brain. So we obtain the benefit of addition of whole brain, but we omit the toxicity associated of whole brain, for example, by addition of memantine. Is that a feasible strategy? And then second question is, in your publication in Green Journal, Dr. Palmer, you stated that gamma knife is associated with increased frequency of radionecrosis compared to LINAC-based SRS. And you mentioned in your discussion, one of the reasons is probably dose inhomogeneity and higher dose of gamma knife. Can you explain more about that? In gamma knife plan, the higher dose is, and the inhomogeneity is supposed to be inside the target, right? So can you explain more the reason of higher chance of radionecrosis by gamma knife? And then the last question is, in a few publications, especially about SBRT SABRE, they have a criteria, R50 criteria. So the 50% isodose volume divided by PTV volume, and they use that as a parameter to determine whether an SBRT or SRS plan is acceptable or not. Are you using that criteria also for your SIMT plan? Thank you.
Okay, please, Dr. Palmer or Dr. Andrea. Dr. Palmer.
Those are great questions that you bring up. I think yes, I think we often, at least in the United States, we sort of can push people a little bit too far to the road of using radiosurgery for everyone. But I agree with you that there's a much higher rate of distant brain failure, and that's a much more common phenomenon in situations where systemic control is not adequate. So if a patient's systemic disease is not controlled well for an extended period of time, they'll continue to fail distantly in the brain. The local control should be better, with radiosurgery, but they will require lots of salvage treatment and a lot more MRIs. It's a more costly follow-up regimen and more costly for potentially for the health system if you need to salvage these patients a lot. And so I think that yes, hippocampal avoidance in memantine is a good solution. The challenge is that if you look at the data from a cognitive perspective, the clinical trial, the Vinay Gandhi's clinical trial CC001 improved the whole brain toxicity by about 10%. And so it's not as good as the data like Andy shared from N0574 and N107C, although it's not apples to apples because the majority of the CC001 patients were numerous brain mets. The Alliance trials were limited brain mets. And so there is going to be a difference in cognitive outcomes when you compare those different patient populations. The sort of improvement of about 10%, about 40% cognitive decline with hippocampal avoidance is still slightly worse than the 20 to 30% we think you can get with radiosurgery based on the Alliance studies. And so I think in situations where patients are likely to, especially if it's, you see in the patient populations that you're treating, if it is a common phenomenon to have to salvage these patients numerous times, I think that using hippocampal avoidance is a good opportunity. Like the study we have for the brain met velocity speed, if it's intermediate or high, I think those are the patient populations where it can make sense to give hippocampal avoidance earlier in their disease course, because you may be actually improving neurologic death and you may be improving sort of the overall brain control and changing the rate at which they see new disease. So I do think that yes, I think for that situation where you're dealing with patient populations with high numbers of failures, I probably would limit radiosurgery to a limited brain metastasis patients. So patients with 5 or less brain lesions, because when you get over 5 and especially over 10 or over 15, you have to have good systemic control mechanisms like more advanced targeted therapies, immune therapies, or combination therapies to gain better control so they don't fail distantly often. Because if, in the examples we used that she had where we were treating 20 and 30 lesions, they were on next generation TKIs. Or on next generation therapies. And so that had high brain penetrance. And so if you're on those types of medicines, then it can make sense to get a little outside the box and treat sort of how we currently are. But I think in a situation like you describe, hippocampal avoidance whole brain in memantine, and typically, like when we talk with Paul Brown, if you start the memantine like a week before the treatment starts, like when you meet the patient, and then start the hippocampal avoidance when they're on sort of the BID or the 2 in the morning, 1 in the afternoon dose, they may do quite well. And I think we also, I don't want to be so strong with radiosurgery. The data that we showed that was pulled from the Alliance study. If you looked at some of the long-term quality of life, emotional well-being, the social and family well-being was actually improved in the whole brain arm. And so there are some components of the quality of life measurements that are improved in patients that don't have distant brain failure or have a number of different salvage therapies. And so, again, although there's a higher rate, the absolute numbers of patients that have 2 and 3 standard deviation declines in cognition are still very low. And so, yes, we want to prevent it if we can, especially if a patient's going to live 3 or 4 years. But if a patient's going to live on average like 6 to 12 or sometimes 18 months, if the systemic disease is not controlled, then I think it's less of an issue and more of an issue of control, and you would get better control with whole brain. Now I'm kind of forgetting your second and third question.
I had a quick question to piggyback onto that one. How available is memantine in your country? Because our patients here, it's actually very expensive for many of them, or we have insurance issues covering it for a good half of my patients. So I'm just curious if that is something that's more readily available in your country.
Yeah, Dr. Henry, would you like to?
I think Dr. Tiara can answer about
Yes,
memantine.
Dr.
Because
Tiara,
it's
our
belong for neurology.
I think maybe it is Dr. Tiara can give also a comment about the time.
Hello.
Oh yeah, I can hear you.
Dr. Tiara, you are.
Well, we cannot hear you, Dr. Tiara.
Okay, is my voice?
Yes.
Okay,
Now we
thank
can
you.
hear you.
Usually we don't always do memantine or other cognitive therapy for patient with brain tumor, but we do have the medicine, but unfortunately it doesn't covered by our national insurance, so that's why. But we only give for selected patient who already got the cognitive examination and it is indicated to need that medicine. Yeah, thank you.
Thank you.
Okay. So maybe we should move on to Dr. Handoko's second question. It's on, Dr. Palmer, your Green Journal publication of the comparison between, or Dr. Handoko, do you want to repeat again the question?
Yeah, so it's about the reason of higher chance of radionecrosis with gamma knife compared with LINAC. You have mentioned something about dose inhomogeneity and then higher central dose. Yeah, can you explain about it?
So the keys to remember for that publication is that essentially it's a retrospective propensity match from two institutions, two high volume institutions. It was us in Wake Forest, Mike Chan's group, which is a very large gamma knife group. And we use similar definitions for radiation necrosis, but because they are a very big gamma knife center and we're a very big SIMT center, we compared the two and tried to match based on all of the available factors. Now, you asked the same question that Ian Paddock asked me as soon as that paper was published, that because he also was not he didn't really want to believe it. What I would say is that the Gadget trial, which was the Italian study, randomized trial, gamma knife versus SRS, showed a very similar finding when they published their abstract a few years ago at SNO, that for some reason, and I guess to answer your question, that needs a follow-up study. We weren't equipped with the dosimetric data on a patient level to be able to answer that question. So we matched based on V12 and dose and volume, number of brain lesions, and then patient-specific factors, but we couldn't match on other dosimetric factors because they weren't available. And so to answer that question well, we would have to go back and rerun and compare plans with similar dosimetric sort of factors, looking at both single fraction and multi-fraction treatments, and try to get to the nitty-gritty. I think we presumed that it can be different due to how those are prescribed differently. So the SIMT plans really only get about 140% hot versus prescribing to the 50% isodose line for the majority of patients. Those plans get much hotter. And so when we're dealing with treating multiple lesions, because remember that what we're really looking at in that paper is treating multiple lesions. So I think when you're talking about one or two or a low number of tumors spaced far apart, I think that, in the vast majority of situations, gamma knife still has a relatively low rate of necrosis. But when you're treating 5, 10, 15, 20 lesions, I think there can be some benefit to the overall coolness and homogeneity of the SIMT plans. Now, the other thing that I would that I don't want to kind of make Gamma Knife feel so negative is that the overall absolute number of radiation necrosis events is low in both arms. So although we did show a higher relative rate of radiation necrosis, the rate in both arms is low. And so the less than 5% in both Gamma Knife and radiosurgery. So it's not that we see an exceedingly high rate of radiation necrosis in Gamma Knife, it just is less with our SIMT. And it seems to be that also seems to hold true even in the randomized trial where they're actually controlling for the dosimetric factors in the GADGET trial. Now, for whatever reason, it's been 3 years and the GADGET trial is still not published. So who knows, we can read into why that may be. But I think that for whatever reason, there's something about the SIMT planning that when you're treating many lesions, I think there might be a benefit. That I think it's still an open question to answer why that is. What dosimetric factor, whether that's something that's the low dose wash or the high dose volume around the lesion, that seems to be the real reason why these patients are like the abutting dose clouds of lesions close together. It's still something that we don't have a good answer for. And in terms of the R50, like you mentioned, we do things like that for lung SBRT, but our dosimetrists do put on 50% isodose line treatment planning volumes to push that 50% isodose line so that it gets an optimal dose fall off. You could think of it as similar to like prescribing to that 85 to 90% isodose line so that you can get that steep dose fall off similar to the 50% with Gamma Knife. But we don't, at least we don't in a routine clinical basis, look at the R50 as a metric. We typically look at the conformality index and some of us will look at the gradient index, but we don't typically look at like an R50 on treatment plans to say that we want to change it. But that being said, when you use things like HyperArc, which is sort of the next generation planning techniques that Varian's released, they do have 50% isodose line structures that get pushed for optimal planning. And so those things are important. They're just not something that routinely we look at.
Okay, thank you very much.
Okay, thank you, Dr. Palmer. And Dr. Tiara, our panelist from the neuro-oncologist, do you have comments or something to add to the topic?
Yeah, thank you, Dr. Mayang. Actually, I'm very interested to this topic because as a neurologist, we should choose maybe which one do we prefer to tell the patient that they may have the SRS or WRT. And from the slide from Dr. Andrea, I see that the cognitive decline is significantly different after 6 months after radiotherapy, right? But actually, our patient survival is not as high as that time. So we eventually have maybe 3 or 2 or 6 months after they diagnose as brain metastasis. So in that particular short time, we see from your slide that SRS is more benefit in cognitive decline. So that's give me a new perspective, I guess, to choose which patient that may we consult to SRS or WBRT. Maybe you can give comment for patient like that. Thank you.
Yeah, I would say the data even did show a difference at the 3-month time point. So I think if we focus more on 6 months, I think that you could argue that there's a greater benefit for a patient who's going to be living obviously for 6 months or longer. But there was also a significant difference at the 3-month time point as well. I think though, the important thing about all this data is we're presenting the facts, we're presenting the numbers, but all of this has to be interpreted in the setting of the resources that are available and what's feasible for the patients to do. So while we did technically also see a difference at 3 months, I think, as you've mentioned, the real people that probably get the most benefit in relation to the resources available are going to be those patients that live longer than 6 months. I mean, it's hard to put a firm line on it, but I think that'd be the population to focus on.
Thank you.
And that's also true for the hippocampal
Yes, thank you.
avoidance. Because the key from Vinay Gandhi's data is that there really wasn't a difference early on, whole brain versus hippocampal avoidance, unless they lived more than 4 months. And so it's really meant for those patients that are longer term survivors. The ones that are surviving less than 3 to 4 months, I think the key things that you would want to prevent in those patients is the acute toxicities and things like, well, and so there was a nice paper in JAMA Oncology that showed you could actually spare some of the parotid glands. And so we would typically spare, if we're doing like a conventional whole brain technique, an underrepresented toxicity in patients, even if they only live a few weeks, is a moderate to severe dry mouth that occurs because the typical conventional whole brain fields don't draw the parotid glands and treat through them, and so they can get that. And so if you draw them in and spare them, you can actually spare that toxicity that patients may not, talk to you about. And so that's even seen 4 weeks after treatment. And so even in a short-term surviving patient, I think with whole brain radiation therapy, there are some things like that you can actually help prevent some of the side effects early on while they're sort of coping with their disease.
Okay.
Thank you, Dr. Jus.
Thank you, Dr. Tiara. And I would like to invite our next panelist, Dr. Widi.
Yes.
Dr. Widi is from the neurosurgeon. Please, Doctor.
Yes, thank you. I would like to give a comment and of course question from the neurosurgical side. Fortunately that we together with radiation oncologists in our department also implementing Gamma Knife for treating some patient for also for metastatic. But the situation is like this. The SRI's procedure is right now is not covered by government insurance. So most of the patients are self-paid or private insurance patient that are only little number of the patient. That's why if we see the number of the treated with SRS for the metastasis, as has been mentioned by Dr. Henry, is only about 40 to 50 patients, while we are only 2 years with our Gamma Knife is only 30 patients. So this is a very big constraint to us why maybe whole brain radiation therapy is still being the first choice in our country, especially in the center which don't have, the high technology of radiation therapy. Do you have any suggestion for us, especially with your experience? Ohio is, I think, is a very good example for us because you have also Gamma Knife, you have also this high technology of single stereotactic radiosurgery. What should we do? What should we do to encourage that we should have a lot of more number of the patients that can be treated with these methods? I think with your very comprehensive presentation, this should be the first choice, of course, if regarding we don't think about the expense or the payment of the patient. This is, I think, what should we do? But thank you for your very nice presentation. It's very comprehensive, and we learn a lot from your presentation. Thank you. Yeah.
Yes, thank you, Dr. Widi. Dr. Andrea or Dr. Palma, would you like to comment?
I just want to say thank you again. I'm glad you guys appreciate the talk, and just having everybody here today is great, especially from all the different specialties. I mean, between neuro-oncology and neurosurgery, this is a big endeavor to bring everybody together. I think, unfortunately, from a U.S. perspective, it's hard for me to think of. I feel like the science in the ideal situation backs up using radiosurgery, but we have to match the ideal situation with a resource limited situation. And how do you make those two meet and balance that out? I think as earlier when we were alluding to potentially looking at more extended use of hippocampal avoidance, whole brain radiation, and then radiosurgery for patients that then progressed past that may be a good way to divide that up and even out the resources a little bit. I don't know. I know that Professor Tati is also good with advocacy and getting the government to, recognize these issues and help and support. I know you were talking with me about your pediatric center you were working on. So that may be something where from your perspective, there may be ways to advocate and get better governmental support for patients, especially if you have it aligned to when they may be also introducing immunotherapy or more advanced systemic therapies that are available to patients, like making sure that those avenues develop in tandem for treatments that are available to people in the country. It may be good to, if there's ways to tie that into increasing government awareness and government funding and advocacy work, that may be the avenue there.
Okay. Yes, I think government funding is the key for the success of this kind of treatment.
Because most people in the U.S. could not afford to pay for this out of pocket either. Almost all of it's either covered through insurance that you get through your employer, because we have a very different health system. Our insurance is tied to premiums that we pay at work. But almost nobody if they had zero insurance and had to pay out of pocket, no one would be able to. Very few people could afford it. So that's the way that we have it work here.
Yes, and yes, also in your paper, as I know, is that some of the patients are died because of the brain fractures. Usually when we do treatment for this metastatic, most of the cause of the death is from the primary problem. But I see that you have also the numbers of patients that died by brain fractures after the treatment. Can you explain about this? Only a small number, I think not more than 15%, right? 10 to 15%.
Yeah, I mean, neurologic death has become a more significant problem. It was a very rare problem when most patients died of systemic disease. So like before immune therapies and before next generation, second, third generation TKIs, the systemic disease burden, and it still is for most patients, is the driver of survival. There's a small proportion of patients that have excellent disease control. Some of these are breast cancer patients that will have really good systemic disease control, but uncontrolled or even leptomeningeal disease in the brain, and then die in neurologic death. And so of those 10 to 15%, the majority of those neurologic deaths are either due to uncontrolled high-grade radiation injury, which is rare but does happen, but the majority are from classical leptomeningeal disease. And so the studies that we're trying to run now is trying to find that population of patients and prevent them. And so the purpose of that hippocampal avoidance, early hippocampal avoidance as a salvage therapy for high brain metastasis velocity is specifically for that patient population. Because in the US, most institutions at larger centers salvage with radiosurgery, 5, 6, or, unlimited number of times as long as the patient's alive, and can be doing it for years. Now, that's when we started to see this 10 to 15% of patients would die of a leptomeningeal disease. Part of that is patients who had operations. So, and then we're running studies now looking at preoperative radiosurgery, because we think that because of the lack of whole brain use in the US, we see now this nodular and classical leptomeningeal disease more frequently, and it seems to be tied to hemorrhagic lesions that are resected, especially in the cerebellum, that you see leptomeningeal failures. And then those leptomeningeal patients are extremely difficult to treat. There's almost, even in the US with our next generation drugs, in Europe, it's very difficult to treat that patient population. They typically do very poorly and die neurologic death. And so the hippocampal avoidance early on for salvage is trying to improve the neurologic death in those patients, but we're also going to run a phase 3 trial looking at preoperative versus postoperative radiosurgery for a resectable brain metastasis. So a lot of us, even without that trial, have already changed practice to doing preoperative radiosurgery when it's feasible, because we've seen this higher rate. And Dan Cagney at Harvard and others, Scott Soltis at Stanford, have published their series showing that there's this high rate of leptomeningeal disease, high rate of neurologic death in those particular patients. And so we do see this neurologic death, but it seems to be more prominent if the patients have systemic disease control.
Thank you. Thank you very much.
Okay, thank you, Dr. Widi. May I move on and invite our next panelist, Dr. Abrar, also a neurosurgeon, if you have any question or comment on the topic, doctor, please.
Thank you very much, Dr. Mayang. Thank you very much, Dr. Andrea. Very nice talk and very comprehensive information for us neurosurgeons, how to complete our treatment in terms of brain metastasis. Can you hear me, Dr. Mayang?
Yes, perfect.
Okay. This is questions that usually neurosurgeons think that usually in brain metastasis, we know that there's a massive peritumoral malignant edema swelling around the lesions. So, and some of the patients after radiosurgeries come to us with the decrease of consciousness, and we should take out the bone for the compressions. In terms of multi-target radiosurgery, do you have a experience the radiations induced after radiosurgery with the multi-target and the whole brain radiotherapy? Which one is the more massive swelling induced after radiosurgery or whole brain radiotherapy? And can we predict this patient will go to the malignant swelling of the brain after radiations or not? So we can prepare the patients, maybe if the patients have a decrease of consciousness or what, we can take out the bone.
Thank you. That's an excellent question. I think both Dr. Palmer and I can comment on this. Yes, at least I personally, and I think in the data that we have, show that there's an increase in the risk of radionecrosis, or at least the swelling and that reactive inflammation that you're talking about, especially in larger lesions, lesions over 2 centimeters in diameter. Sometimes if you use the fractionation approach that you use can impact it as well. I think using a single fraction for a larger lesion can impact outcomes. And so I frequently do see in my patients that we have some degree of swelling post-therapy. And sometimes this requires a visit to the neurosurgeon for resection of the lesion, but most of the time I initially attempt to manage it with steroids. And I know there's some differences in the different consultants within our group, but in general, many of us will do a short course of tapered steroids after they complete their radiosurgery treatment over the course of 15 days or sometimes 3 weeks. We will start them with a small dose, sometimes 4 milligrams twice a day for 5 to 7 days, and then go to half of that and then half again, and then have the patient stop. It is a risk when we treat, but especially with the larger lesions. And I've also seen issues with the posterior fossa lesions, like the cerebellar lesions seem to, for some reason, again, associated more with a leptomeningeal disease anecdotally, and potentially with a bit of a higher rate of necrosis. But I'll let Dr. Palmer speak to that as well.
And your question is more about like the acute side effects, like doing the treatment and then immediately taking them, right?
Yes.
So that happens, but it's relatively rare. I think in my experience, when our practice at least is we don't use single fraction radiosurgery for large resectable lesions. We fractionate, and so we choose to fractionate with 3 treatments, large edematous lesions out of safety. We do the same thing for numerous lesions. So if we're doing radiosurgery for 10 or more, and usually 15 or more lesions, we fractionate because of that fear of radiation injury acutely. And so at least I've done some relatively high risk lesions, like compressing the 4th ventricle, tumors that are already causing some degree of hydrocephalus. Doing it in a fractionated radiosurgery approach on high dose steroids and then tapering after they're done, I haven't had that problem. I have dealt with seizures both on radiosurgery and with whole brain patients from swelling, but typically not so much like an acute hydrocephalus requiring acute management with neurosurgeons. Commonly, we can, by using fractionated approaches, hopefully not get into that situation. The other key is that if we're seeing lesions, and I guess it would depend on which type of lesion you're talking about. If we're giving radiosurgery to a resectable lesion, we would want to plan to do the surgery right after. So there are certain tumors, like 3 or 4 centimeter tumors that we've treated, that will do preoperative radiosurgery and do the surgery the day of the last treatment, knowing that if we were to wait, that those are the high risk lesions that if we do wait, they're likely to have a problem. And so those individuals typically get a planned surgery up front to remove that larger lesion. That's sort of the patient population for preoperative treatment that we choose to do, that we think we can gain some control. At the moment, we believe there's less radiation necrosis, less leptomeningeal disease if you do the surgery after radiosurgery. And so those types of high risk lesions, so if there's a larger lesion with lots of edema, or hemorrhagic lesion with lots of edema, those are the types of lesions that we would want to try to work with neurosurgery to plan an early surgery if we are that concerned. So that we don't run into, treating a patient and then having them come into the ER kind of comatose because they're completely blocked and need some sort of emergent surgery. I think that if we start to get into a practice pattern where you're fractionating more or having people on higher doses of steroids during the therapy, you'll still see seizure. It's hard to predict and treat patients prophylactically for seizure if they've never had one. And so there still are going to be some patients that during or right after treatment can have seizures after the radiosurgery. We did publish in neurology like a nomogram to try to predict, but we still don't do, at least our practice isn't, and I'd be interested to see what your neuro-oncology practice is. We don't usually prophylax against seizures, even if they're high risk. We usually wait until they have it and then treat them.
Thank you so much. Very good. Very nice.
Yeah.
Okay, thank you, Dr. Abrar. I am very sorry that we are already way past our planned schedule. So I know, I mean, the discussion is still ongoing. It's far from the end. So, but unfortunately, I think we have to end our session today. We actually have so many participants, even more than we expect, more than the registered participants have joined us today. And it's very good response as we have so many questions coming in still. I know there are still many unanswered ones, but we actually plan to finish. The limit is 2 hours, and we are even already more than 2 hours. And it is
We can also, if you want to collect the questions, people are welcome to reach out to all of us. And I'm like both Dr. Palmer and I are happy to answer questions and have email exchanges and get everybody involved. So I'm happy to follow up on all that.
Great. We'll do that. So because it's already past 11 p.m. over there, we don't want to keep you until midnight there. And so don't worry, as we'll note of all the questions, and I will forward them to Dr. Andrea, or decided that this will become a webinar series. So we will meet again. And if you're still not happy with the written question or answer, then you could ask again in the next session. So now I would like to kindly again invite Professor Tati to give a...
Yeah, okay, thank you very much, Dr. Mayang. I'm sorry, it's already 11:30, almost 11:30 there in the file. So I'm sorry, Andrea, but I hope that we will have another session for the discussion about the brain met discussion like today. So, but as it is mentioned by Andrea, all the questions will be answered by email. So please give your email address, and then we will, Andrea and Joshua will answer that question by email. So just a summary from our discussion for today. I think the whole brain irradiation and SRS is still better survival from survival point of view, and reduce the need for repeat or salvage treatment. But the problem is of course the cognitive impairment. And what is the best treatment? Finally, it depends on the facilities, because our countries is very large from here to there, consists of 17,000 islands. So, and maybe we have to explore more with the high technology of MRT, possible hippocampal sparing to reduce the cognitive impact after the whole brain irradiation. Also for the information for all our friends from neurology and neurosurgeon. Nowadays, there are many good equipment, radiotherapy installed in some of the cities outside of Jakarta from the military health system and others. So it is not possible that maybe we can more explore to do the hippocampal sparing whole brain irradiation. And I was thinking maybe because there is a question from Dr. Setyowidi about the BPJ, our national health insurance to cover the stereotactic radiosurgery services. From the cost-effective point of view, it is maybe easier for the radiotherapy center to equip the LINAC with the cone beam and then thin MLC, and most of them they can do already MRT. So the LINAC-based stereotactic radiosurgery is more easier to be done in our country. Yeah, our country is not a high-income country. we are still in the upper middle income countries, so the budget is also not so high for the Gamma Knife that is dedicated just only for the radiosurgery. But if we use the LINAC-based radiosurgery, it is more cost-effective, since that the LINAC itself we can use for other purposes of radiotherapy than stereotactic radiosurgery. And the last is about the preoperative radiosurgery. So maybe Dr. Vidi, we have to think more about these possibilities. How can we extend with our friends neurosurgeon from all over? Because I know that here in this session we have a lot of neurosurgeons also in this session. So how can we more extend the preoperative radiosurgery to get a better result of the brain metastasis management? So thank you very much for everybody, for Andrea, for Sua, and Nicole also for you to be here, and all our panelists we have here, Dr. Tiara, Dr. Abrar, Dr. Setio Widi, also Dr. Arnab, Professor Arnab Sakrawati is still here. Also, thank you very much. We hope that this meeting is not only the first, but there will be another meeting with the topic of brain metastasis. It's very interesting. There are still 7 questions in the question and answer box that is not yet finished for this time. So thank you very much. So all stay safe and stay healthy and safe for all of you. Thank you very much.
Thank you. Thank you so much.
Thank you, Professor Tati.
Yeah.
Thank you. Terima kasih.
Thank you, Dr. Andrea, Dr.
Thank
Joshua.
you. Terima kasih.
See you all later.
See
See you.
We'll see you.
Thank you, Dr. Maya.
Terima kasih, Dr. Tiara.
Thank you. Bye.
Terima kasih, Dr. Widi. Bye, Nico.
Terima kasih, Dr. Andri. Terima kasih, Dr. Mayang. Terima kasih,
Dok.
Dr. Tati. Saya izin leave.
Dok.